Hello, everyone. Thank you so much for joining another episode of Heart Trending. I'm really privileged to be with another internationally renowned speaker, Dr. Nicolas Van Mieghem. I know Nicolas since I was a fellow. That does not represent his age. He's young as well, but he has been involved in multiple structural heart, especially procedure and trials since the beginning of transcatheter therapies. So Dr. Van Mieghem is a professor of interventional cardiology at Erasmus University in Rotterdam. He obtained his medical degree and cardiology degree at the Catholic University of Leuven in Belgium. After a subsequent fellowship in interventional cardiology at Ziekenhuis, I'm sorry for the pronunciation, in Belgium, he went to Lenox Hill, New York, United States, and Thorax Center in Erasmus University Medical Center, Rotterdam, and Netherlands. He joined the senior staff of the Department of Interventional Cardiology in the Thorax Center in February 2010. Dr. Van Mieghem, professor, is interested in the complex calcified coronary lesions, mechanical circulatory support, and structural heart intervention. He obtained his PhD based on his research in transcatheter valve therapies. Professor Van Mieghem is involved in the percutaneous coronary intervention and structural heart program in multiple trials, as I mentioned earlier. He publisher and co-author more than 700 scientific papers in peer-reviewed journals, and he's a principal investigator and a steering committee member on multiple ongoing international trials evaluating various coronary and transcatheter valve technology. He's a fellow at the European Society of Cardiology and the American College of Cardiology. Dr. Van Mieghem, thank you so much for being with us. I'm really delighted to have you today. This is the last session of the year in 2025, and we're going to talk today about next generation transcatheter therapies for mitral and tricuspid regurgitation. Where are we now? Thank you so much.
Thank you very much, Chadi, and thank you for having me on these Heart Trending series podcast. It's a true privilege to be part of this great initiative. So what I will do in the next 45 minutes or so is give you an overview of where we are now in terms of transcatheter atrioventricular therapies, valve therapies. And I want to keep it broad, so I will touch upon some technologies, but I definitely also want to highlight what our objectives are and how to get there. So these are my disclosures. And please also interrupt me when there are questions or comments, then we can deal with them as we move forward. So first of all, I think it's very important that we have to realize that there is no one size fits all when we're talking about the treatment of atrioventricular valves, so the mitral or the tricuspid valve. We have to take care of, we have to be considerate of the mechanism. We have to talk about patient risk phenotype. We also need to discuss the strategy that we want to use to treat a disease. And then we have several technologies. So let's, if we think about the mechanism, then we have to separate primary and secondary disease, and that counts for mitral and tricuspid. In terms of the patient risk profile, is it a high or a low operative risk patient? Strategies, it's either surgery or catheter-based. And in terms of technology, well, we either strive for a repair or a replacement of the valve. Now, let's first zoom in on transcatheter solutions for tricuspid regurgitation. And the European guidelines on valvular disease have been recently updated at the last ESC meeting. And there have been some new developments and new insights. And I think an important one in terms of the mechanism is not only are we talking now about primary and secondary tricuspid regurgitation, but also electric device leads related tricuspid regurgitation has become an important entity, and I will briefly touch upon that later in my discussion. So it's very important then also to take into consideration the patient risk profile, and embedded in the risk profile is RV dilatation, RV dysfunction, and pulmonary pressure. So that means that if you want to do a complete workup for a patient with tricuspid regurgitation, it's not just echocardiography, but it is a mandatory right heart cath to obtain the full picture and to be able to risk stratify a patient properly. And then it depends on whether or not you need to complement this with also CT or MRI imaging. In terms of how to deal with patients with tricuspid regurgitation, the guidelines have been updated in a way that now also transcatheter strategies have received a recommendation. And this is new and different from the guidelines of 5 years ago. Now there is a 2A indication for transcatheter treatment of tricuspid regurgitation in the context of high-risk patients. So still surgery is the go-to treatment, but we know from the surgical literature that the operative mortality is relatively high, and that all has to do with the risk profile of the patient. So a significant number of patients will be at an elevated operative risk, and we also have to bear in mind that the majority of the patients with tricuspid regurgitation who will require treatment are patients with secondary tricuspid regurgitation. So they have some kind of left-sided heart disease in the majority of cases. So that is an important concept. But at least what is now new is that there is a 2A indication to consider transcatheter strategies for patients with tricuspid regurgitation.
Dr. Van Mieghem, just want to pause here for especially the guidelines. So for surgical, there is no guideline saying surgical repair or replacement of tricuspid for only one valve problem, correct? You have to go in for something else.
Yeah, that is correct. That is correct.
But here for transcatheter, you can go in after the valve only, which is a tricuspid in symptomatic high-risk patients.
Yeah, exactly that. But obviously there are multiple layers that have not been addressed in the guidelines, and I hope to touch upon them a little bit later on.
Please, yeah.
Because obviously when we look at tricuspid regurgitation, and I already mentioned the difference between primary and secondary, but in almost all of the situations, it deals with an enlarged annulus. And similar to what we see in the mitral valve, also in the tricuspid valve, the valve has a tendency to enlarge in most of the time one direction. And again, 90% of TR is functional and presents with annular dilatation. But for the time being, that is one of the issues that we have, because we don't have a good annuloplasty device, at least a good catheter-based annuloplasty device. We have Cardioband, but Cardioband has never been adopted into everyday practice in most institutions. So it's been limited. And even in centers of excellence, these procedures take hours for results that are not always reproducible. I think a very important aspect of the treatment of patients with tricuspid regurgitation is risk stratification. And I think the TRI-score has now been embraced also in the guidelines as a way of trying to identify patients with futility. We have to take this also with a grain of salt, because if you look at the TRI-score, and these are the elements that are being considered on the left-hand side, but if you have a score of 8 or higher, that means that the mortality of the patients at 30 days, but especially at 1 year, is very high. So more than 50% of the patients with a TRI-score of 8 or above will be dead within the year. And these are quite sobering data coming from the TRI-valve registry. And that helps us also, obviously, with risk stratification and with determining a strategy or an algorithm of the patient. So basically, if you have a patient with symptomatic tricuspid regurgitation, then it becomes very important to measure this TRI-score. It is very easy to evaluate. And once you determine that the TRI-score is less than 8, well, then you have to think about, okay, what are the treatment options here, being it surgery or a transcatheter solution. And this is basically the more or less contemporary landscape of transcatheter tricuspid therapies, and they vary from annuloplasty devices under development, most of them under development. Then, shall I say, the standard, which is edge-to-edge repair. And then there is obviously orthotopic and heterotopic valve replacement. I'm not going to touch upon heterotopic valve displacement. That is really a niche product for patients where no other options are available. And we always have to think there, okay, but are we not treating a futile patient? I think in Erasmus, we treated up to 5 to 10 patients per year with heterotopic replacements, with results that seem to be a little bit more unpredictable beyond 30 days. And then another way of attacking a tricuspid regurgitant valve is the use of spacers. But again, these devices are not in commercial use. If we look at the technologies that are typically being considered in Europe for transcatheter TR treatment, then we are talking about edge-to-edge with either a TriClip or a Pascal device, and the Evoque system by Edwards, which is a TTVR system. Now, if we want to summarize the overall wealth of data, then basically with all the technologies, we are able to reduce tricuspid regurgitation in the majority of cases. But and we have to define what is the effect on tricuspid regurgitation. So if you see with the TriClip, it's more than 80% of the cases should be able to end with a residual TR of moderate or less. In the Pascal data, you reach around 100% of TR reduction, but this is any kind of TR reduction. So it's not separated in mild, moderate, or moderate to severe. And I think the best results in terms of TR reduction are being obtained with transcatheter valve replacement with a TR of mild or less in almost 100% of the cases. So TTVR practically eliminates the tricuspid regurgitation, whereas tricuspid TEER will reduce the tricuspid regurgitation. But the effects that we can anticipate are also important. So I don't think we can claim that by treating tricuspid regurgitation, we will prolong life. The ambition should be, or the objective is, we want to improve the quality of life, and also we want to keep the patients out of the hospital. And this is exactly what we're doing with tricuspid TEER. And the interesting aspect here is that the Triluminate pivotal trial in the United States is here the crucial study that at 1 year was not able to show a difference in heart failure hospitalizations between the patients that received a TEER versus medical management. But after 1 year, that is where the curves started to separate. And I think this is a very important notion. So you will probably improve the quality of life relatively early, but to see a difference in hospitalizations, we will need to follow up our patients a little bit longer. That said, the number of TR reduction is one-to-one correlated with reverse remodeling. And this is also an important concept that defines the objective, the target of our treatment. So the target should be, we need to reduce severe tricuspid regurgitation to at least moderate, but preferably less than moderate. And when we are doing that, we will see also reverse remodeling. So the end diastolic volumes of the right ventricle will go down if the tricuspid regurgitant volume is lower. And you also see these effects here when there is a larger reduction in tricuspid regurgitation, then you also see an increase in the effective ejection fraction of the right ventricle. And these are also illustrated by improvements in right ventricular volumes, but also in right atrial volume, and also in changes in the size of the tricuspid annulus. So the more you reduce the tricuspid regurgitation, the better and the more pronounced the reverse remodeling will be. We also did some research on this in Rotterdam, where we used invasive pressure volume analysis, so the pressure volume relationships on the right ventricle and the left ventricle. And what we found consistently, if we were able to reduce the TR to moderate or less, then we see an immediate increase in the end-systolic pressure-volume relationship. And this means an increase in the RV contractility, which is quite impressive. At the same time, you also see an immediate volume unloading, so a shifting of the curve to the left. This is what we saw on the right ventricle. On the left side, we see that the preload of the ventricle is increasing. So you see a shifting of the pressure volume loop to the right, provided that you reduce the tricuspid regurgitation significantly. So if you do not do that, and this is illustrated here, this is another study that is in press from Rotterdam. We are comparing here a couple of patients who received either TTVR, so an AVOC transcatheter valve replacement, or a TEER. This was a TEER with optimal TR reduction, so a mild residual TR. In this patient, there was moderate to severe residual TR. And then clearly you see that you see again this NRAP effect, and the NRAP effect is that the contractility of the RV increases with an increase in afterload. So if we close the back door due to the tricuspid regurgitation, and if we improve the tricuspid regurgitation, the afterload will increase. But in parallel, you see an increase in contractility, and the result is that you see either a stable or an improvement in RV pulmonary coupling, and that is an immediate phenomenon. In parallel, you also see that the PV loops on the left ventricle is shifting to the right, so you see an increase in preload there. These effects are less pronounced or even absent in patients with suboptimal TR reduction. So you see no shifting of the loops in the right ventricle to the left-hand side, and you also see no shifting of the loops to the right-hand side in the LV. So again, a clear attestation to the goal of tricuspid regurgitation treatment. It should be less than moderate or less. Now, the pivotal study in terms of TTVR is the TRISCEND-2 with the AVOC valve. Also there was an immediate improvement in the quality of life of the patients and in their symptoms. But what we did not see in that particular study was that there was no effect on heart failure hospitalizations. That seems to be a surprise, but we have to bear in mind that this data from the New England paper only looked at patients out to 1 year. And we already saw in the Triluminate that the results in terms, or the benefits in terms of heart failure hospitalizations only become evident beyond 1 year. So I think it's going to be very important to look at those data. And it's also critical to realize that TTVR as a procedure is more comprehensive and also a higher risk procedure than a conventional edge-to-edge repair, with a higher mortality risk, more bleedings, and also a risk for conduction disorders that may require permanent pacing. Now, let's briefly focus on TR that is related to these electric leads, to ICD leads or pacemaker leads. Well, then there are two scenarios. Either the TR is in the presence of the lead, but the lead has no significant impact on the TR, or the TR is related to the lead. And that is a fundamental difference. And this is not really rare. So in patients that receive these pacemakers and ICDs, up to 20% of those patients will experience at least 1 grade of TR worsening. That's quite significant. So we definitely need to I think, refine the follow-up of patients who receive these devices, because a lot of those patients, or a significant number of those patients, will experience some degree of TR that may become clinically relevant. And obviously, time is of the matter. You don't want to treat these patients when their ventricles are completely worn out and blown up, because then obviously the tri-score is going to increase and the results will be less.
Dr. Van Mieghem, just for the previous slide, Can you spend some time on the mechanism just for the audience to differentiate about association and related TR, especially in this disease state?
Yeah. So the main difference is that in the lead associated TR, basically the lead and the TR, you make the observation that both are present. So you have a lead and you have TR, but the TR is not induced by the lead itself.
So
it's a bystander.
Yeah.
And that doesn't mean that you don't need to follow it up or that it's a rare event, because it can happen in up to a third of patients with a lead. There is concomitant TR that is not associated to the lead. On the other hand, when it's related, when the TR is related to the lead, then either the lead has perforated the valve, one of the valve leaflets, or it impinges or it freezes one of the leaflets, and then the TR is caused by the lead. Obviously, there are then multiple ways of dealing with it. Either you can need to do a lead extraction and see what the effect will be on the tricuspid regurgitation, and sometimes it resolves the issue of TR, but that's not always possible, right? Some patients are lead dependent, and then obviously you have to come up with different scenarios, and oftentimes that is going to be surgery.
Right.
All right. So the TTVR experience with EVOQUE, our good friend Santiago Garcia presented at TCT an interesting analysis. 435 patients who received TTVR with the EVOQUE valve. Approximately 50% had no lead, a third had leads up front, and another 12% had a lead placed after the TTVR. Again, TTVR is associated with conduction disorders that may require pacing. The good part or the good conclusion of the study, and the reassuring conclusion, is that whether or not there was a pacemaker up front in that patient population, it did not affect the results of the TTVR. This is important because that means that patients with lead-related TR can be treated also with a TTVR. So it all depends on the mechanism. And at the same time, when you put in a TTVR with a patient with a lead, you will jail the lead by default. Now, this jailing of the lead may become clinically relevant. So you have to make sure that you analyze the pacemaker, that you look at the thresholds after you jail this pacemaker lead. But in general, you will get away with that, and it's not necessary to do additional maneuvers. That said, there were 10 lead-related events, and they required a new lead or repositioning of an existing lead in the majority of those cases. So you have to definitely keep an eye on those patients. They require specific attention. Obviously, you can also treat patients with a pacemaker or an ICD lead with TEER. It depends on the mechanism, and this is where CT scanning comes into play, because you really have to understand the mechanism, whether or not a TTVR or a TEER is possible. But again, in selected patients in Spain, where they treated patients with an RV lead and with a TEER, the results of those TEER procedures were more or less similar as compared to patients who did not have a lead. But again, this is a selected patient population. Now, Becky Hahn in 2024 published a very nice state-of-the-art review paper on this topic, and highlighting that there is a difference between a TR that is related to the device versus an incidental finding of TR in a patient with a lead. So that is a fundamental difference. But it is important, once you are considering treatment of a patient with a device in situ, that you assess the anatomical suitability for a transcatheter intervention, and you also need to assess, as I mentioned, the risk of jailing the lead. What are the limitations of transcatheter tricuspid strategies for the moment? Well, first of all, there is the issue of residual TR predominantly in patients who receive TEER. There is also the issue of large annuli. The dimensions of the annulus in the tricuspid valve can be so large that we do not have devices to treat those anatomies, specifically for TTVR, but also patients with very large annuli also tend to have very large coaptation gaps, and that makes them also unsuitable for a TEER therapy. So there are still a number of patients where we do not have the technology to treat them through transcatheter techniques. Once you proceed with TTVR, valve replacement, then there is this issue of prosthetic valve thrombosis. This is an entity that is much more common than valve thrombosis, for instance, in the aortic space. And there are still access site complications predominantly with TTVR treatment. And we mentioned the pacer lead management. What you will see in the literature, but also in meetings when experts are talking, they like to refer to green patients, orange patients, and red patients. And that means that this has all to do with anatomical suitability for TEER. TEER is being considered as the reference transcatheter therapy because it's a low-risk procedure. TTVR, in principle, is a more complicated, more complex procedure, and therefore is reserved for those patients with more complex anatomy that are more TEER ineligible. Similar classifications are also being applied in the mitral space. So what are then the challenges for TR? I mentioned the valve size, the annulus size. Imaging can also be a problem. In one of your series, you also looked into the imaging modalities that we have at our disposal in transcatheter therapies. And the tricuspid valve is one of the more delicate areas, if you will, for per procedural imaging, and I think ICE definitely has a role to play in that regard. The issue of pacemaker leads we discussed. Open heart surgery is definitely an option, but it comes at an operative risk, and mortality rates can be as high as 15% depending on the patient phenotype. So what are transcatheter solutions on the horizon? And I will briefly comment on technologies that I'm involved with. One is the Stargazer annuloplasty device by Conkai. They are about to start first in human procedures. And this basically is an annuloplasty device that allows you with one suture mechanism that is connected through screws to shrink the annulus by 50%, by up to 50%. And this is a cartoon animation that explains that with a transvenous transfemoral approach, you will be able to screw in multiple screws along the perimeter of the annulus. The screws are connected with a wire, and then you can cinch the wire. By doing that, you will reduce the annulus. This is a procedure that, at least in animal studies, can be done within 1 hour. So that is quite an attractive. Wow. The other one, and this is called Approxima. This relies to RV restoration, and I've also been involved with multiple in vitro studies. And what you do, the approach is totally different. You are extravascular, so it is an access through the subxiphoidal or xiphoidal space, and it's completely percutaneous. So that is of interest. You do a pre-procedural planning with a CT scan to identify where the papillary muscles are. And then what you do is you first pierce through with a needle through the skin, through the RV, to end up in the LV, and you position a disc, an anchoring disc, at the septal wall in the left ventricle. There is a tethering wire that is connected with an anchoring mechanism on the right ventricle, and then you can cinch the RV. So, and by doing so, you will immediately reduce the dimensions of the right ventricle. By reducing the dimension of the right ventricle, you will also see a concomitant improvement in the coaptation. And in animal studies, this procedure turned out to be reproducible, repeatable, and safe. There was 100% procedural success. They did up to 30 animals, and procedure time, and this is quite impressive, less than 10 minutes. So that tells you that
Wow.
this doesn't require a lot of mental thinking during the procedure. Everything is done up front. The execution is relatively straightforward. And what also is quite attractive, this is 100% echo-driven. There is no need for fluoroscopy. So this is quite, I think, a promising technique. And here, if you look at the echo image, this is the RV, and here you see the device itself. So it looks like a moderator band, an additional moderator band in the RV, with then a disc, a septal anchoring disc in the LV, and another one in the RV. So I think this is quite promising. We also presented data at TCT and at Miami Valves this year, and the first in human is expected for Q2 in 2026. So just some takeaways for the tricuspid. So there is a disputed impact on the heart clinical endpoint. So we have to be realistic. We are aiming for quality of life and heart failure hospitalizations. Most patients will feel better after a TR improvement. It is about adding life to years rather than years to life. And TTVR outperforms STEER in terms of TR elimination. With TR treatment, we are aiming for less or moderate or less residual TR. New devices aim for annuloplasty and RV restoration, as I mentioned. And I think eventually we will have to move towards a toolbox approach with tricuspid repair that will involve multiple techniques. So I can imagine that you would have like an annuloplasty, and then on top of the annuloplasty, you would do a TEER, for instance. Or you do an RV restoration just to improve the coaptation, and then you wrap it up with a TEER for consolidation. So I think this is work in progress, but within the next 5 or 10 years, this will be probably the future, and it may also replace the need for TTVR that is associated with issues like valve thrombosis and major bleedings that you do not have with repair. All right, for the remaining of the talk, I will focus now on the mitral. So mitral anatomy is quite complex. In 2010, I had the privilege to write a review paper on mitral anatomy, only on mitral anatomy in JCC. And we highlighted there that this mitral apparatus is more than just a valve. It's a confluence of multiple structures in the center of the heart, with an anterior or aortic leaflet and a posterior or mural leaflet. And the annulus is a virtual structure that also consists of fibrous tissue, but this fibrous tissue is not circular. And this is important. So it is, the mitral annulus is less well developed, and it is even less so at the posterior leaflets, at the posterior annulus. And that is similar to what we saw in a tricuspid valve, the area that will enlarge when mitral regurgitation starts to occur. It is also a structure that shows contraction, so it becomes 25% smaller during systole, and that obviously is important when you are designing annuloplasty devices. It needs to be able to contract. And mitral annular calcification is another entity that we need to bear in mind when we treat mitral valves. And it's quite common. It's linked to aging and atherosclerosis, and it again almost always starts in the posterior part of the mitral annulus. When we look at the surgical predicate, well, surgeons typically, when they repair the mitral valve, they use multiple concepts, and they use a toolbox approach, but center stage in the toolbox approach is the annuloplasty. And this also comes clear from an STS database review, where annuloplasty was applied in more than 90% of all mitral valve repair techniques, but oftentimes in combination with a leaflet resection or the addition of artificial cords or a sliding valvuloplasty. But edge to edge, from a surgical point of view, is not being applied too often. That said, it is obviously the center stage of transcatheter mitral therapies that we have today, and it can be applied here both for type 1, type 2, and type 3 mitral regurgitations. So for primary MR, the updated European guidelines have granted TEER a class 2A indication for high-risk patients. So in principle, surgery is the gold standard for patients with primary or degenerative mitral regurgitation, but in selected high-risk cases, TEER is a class 2A indication, and there is also not a recommendation, but at least a reference to transcatheter mitral valve implantation in TEER ineligible patients who are at a high operative risk. So that has changed in the current guidelines. What also is important, if you look at secondary MR, that a distinction is being made between atrial SMR and ventricular SMR. And this can sometimes be a matter of semantics, but there are some rule of thumbs that help you determine whether it's atrial or ventricular. For instance, in ventricular SMR, typically the ejection fraction will be less than 50%, whereas in atrial SMR, there is no requirement for depressed LV function. Leaflet motion is typically normal in atrial FMR, but restricted in ventricular SMR. And typically, atrial SMR is in the context of atrial fibrillation, whereas ventricular SMR is associated with dilated ventricle and atria. This also resulted in formal recommendations for secondary MR, and the novelty in those guidelines is that TEER has reached now a class 1 indication, regardless of operative risk in patients with ventricular SMR. And this is, I think, quite a novelty. It's the first time that there is a transcatheter therapy with a class 1 recommendation and not just as an alternative to surgery. It also has a class 2 indication if patients do not comply with the selection, with basically the coapt phenotype, because that is the association or the recommendation. The class 1 indication only relates to patients who have a coapt-like phenotype, referencing the coapt pivotal randomized control trial. In patients with an atrial SMR, the story is a little bit different. Surgery is in principle the first-line therapy, but if the patient is at high surgical risk, then TEER becomes a recommended therapy, but only a class 2B recommendation. So this tells you that there is a difference in approach for atrial versus ventricular secondary MR. And as we also already showed in the tricuspid space, also here we have this color coding with green over yellow or orange to red. The more complex the anatomy, the higher the likelihood that you might want to consider a TMVR over a TEER treatment. Again, why? A TMVR from a procedural point of view still is a high-risk procedure as compared to a TEER that is a low-risk procedure. So if anatomically a patient's phenotype is suitable for a TEER, TEER should be the recommended therapy. But there are several limitations for TEER. leaflet calcifications, the presence of cleft, excessive tethering, small valve areas, broader jets into the commissures, and excessive leaflet tissue and prolapse may preclude good results with TEER. And then obviously other therapies come into view, predominantly then TMVR. Now, important with the COAPT trial, and that was the pivotal study, as I mentioned, is also the definition of procedural success. It is important to aim for moderate or less residual MR in patients with secondary MR. This is important. So the COAPT trial only involved patients with ventricular secondary mitral regurgitation. And in those patients, if the residual MR was grade 2 or less, those patients had the best outcome. If it's more than grade 2, you see that the mortality is higher, hospitalizations are higher, and also the composite of the two are highest. But there was no clinical difference between an MR grade 1 or a residual MR grade 2. Now, it's important to realize that COAPT related to patients with advanced heart failure. So what happens after 2 or 3 years? Well, there is no longer a difference between the patients who survived after 2 to 3 years. And if you start then comparing the patients with versus without a TEER therapy, no more difference. All the differences appear within the first 2 to 3 years. But this is as expected, I think, because if you're talking about patients with advanced heart failure, by treating secondary MR, you're not resolving the heart failure, right? So we know that patients with advanced heart failure by default have a reserved prognosis. So, but this is an important concept that, well, probably in those patients, you not necessarily need to eliminate MR, because if you would eliminate MR, probably in patients with a lack of myocardial reserve, there can be an afterload mismatch, and that can jeopardize the outcome of those patients. And again, you have to be realistic when you talk to those patients. The effect of the MR treatment will not be beyond 3 years. Now, we in Erasmus did a literature review to look at the re-intervention rates and the rates of MR recurrence after mitral TEER in the literature. And what we find is that in terms of re-intervention, out to 5 years, it's around 10%. So 1 in 10 of the patients who receive a mitral TEER will need a re-intervention within the first 5 years. This is a relatively low number, but obviously this has all to do with the patient profile. In everyday clinical practice, we are treating sicker patients, and their life expectancy is probably less than 5 years. So they will not outlive the TEER procedure. In terms of MR recurrence, we do see that there is a 10% recurrence rate out to 3 years, and then there is an inclination and an higher. So you see a gradual increase in the MR recurrence rate out to 5 years. And I think this is an important observation for future randomized controlled studies, that we need definitely to prolong follow-up time with core lab adjudicated echo follow-ups to be able to interpret the durability of a TEER result. Because we have to also acknowledge that TEER in a transcatheter, as a transcatheter therapy, is an isolated therapy for the time being, whereas in the surgical space, TEER will always be combined with an annuloplasty. And that probably is something that also will change over time in the transcatheter space. Now, if you look at randomized controlled trials of TEER versus surgery, you have 2 existing randomized controlled trials. The original one is the Everest trial on the left-hand side, and you see this is the Everest, and this is the Matterhorn. This is one of the largest mountains in Europe, and a very dangerous one to climb. This was a randomized controlled study, Matterhorn, of patients with exclusively ventricular secondary MR, randomizing patients to TEER or surgery. The Everest was predominantly patients with degenerative mitral regurgitation. So we have to be very careful with comparing these two trials. But also, the Everest trial presented its results more than 15 years ago, whereas Matterhorn presented the results last year. Well, they had different outcomes. So in Everest, surgery was definitely better than the transcatheter therapy, than TEER, in terms of the primary MACE endpoint. That was not the case. There was no difference between the two treatment strategies in Matterhorn. And again, showing that we were talking about different patient phenotypes. In Everest, 20% of the patients required a re-intervention in the TEER arm versus 5% in Matterhorn. So that tells you that you have to be very careful with comparing these two trials, but at the same time, there is also the difference between degenerative MR in Everest versus secondary MR in Matterhorn. There are some important randomized controlled trials that are focusing on degenerative MR, and again, comparing TEER with surgery. You have Mitra HR in France, you have the primary, and you also have Repair MR. And I think these randomized controlled studies will give us more insights in how to position TEER versus surgery in patients with primary MR. So if you look at the treatment of mitral regurgitation and the expectations and what are the goals, it's different when we talk about secondary and primary MR. In primary MR, probably the goal should be to eliminate the mitral regurgitation, whereas in secondary MR, especially if the LV is poor, you may be okay with reducing the MR to 1 or 2 plus. So the scenario is different whether we talk about secondary or primary MR. Mitral TEER is a relatively safe procedure from a complication point of view. The most important complication, if you can call this a complication, is that there is residual MR of more than 2 plus, and this occurs in up to 15% of the cases today. That is why we also need to consider TMVR devices, and there is a plethora of devices that are one-step or two-step devices. The two-step devices, they typically rely on an anchoring mechanism, and then you implant a valve in the anchoring mechanism. This basically also resembles surgery because the surgeon also will remodel the annulus before implanting a valve. With the one-step devices, for instance, like the Apollo that we are Intrepid that we are using in the Apollo trial, that is a one-step device where you do not remodel the annulus, but you implant a self-expanding valve in one step. That is, I think, one of the reasons why you have also LVOT obstruction. And this is a little bit underrepresented in the literature these days, because if you look at the left ventricular outflow tract obstruction, which is a dreadful complication, look at the numbers. They are single digits numbers that are presented in the literature, but this obviously is due to the highly selected nature of the patients that enter these trials. I am involved with the anchor valve. Anchor valve is also a two-step approach where you create an anchoring mechanism, not around the cords with like we have with HighLife or the M3 device, but really at the level, like a clipping mechanism at the virtual annulus level. And then in that anchor, you implant a balloon expandable valve. This is also under development, first in humans, hopefully by the end of 2026. I think TMVR planning is super key. You need CT scanning to evaluate the mitral annulus, the dimensions. Also, you want to know information about the mitral leaflets, the length, the thickness, and the calcification, especially of the anterior mitral leaflet, and also the sizes of left atrium, papillary muscles, and LVOT are important. We have been very much involved in LVOT simulations. Those are CT-derived simulations where you basically simulate a valve implantation and then you calculate what the residual LVOT area is. When there is no anchoring substrate, this is a very complex evaluation that typically is outsourced and delivered by the vendors. This is not in-house technology. It's a different story when there is an anchoring substrate, for instance, a failing surgical ring or a failing bioprosthesis, or when there is circular calcium, then we already have the in-house tools for advanced imaging and simulation of LVOT obstruction. But we have to bear in mind that the phenotype also determines the accuracy of these LVOT obstruction. And it's well known that in patients with MAC, mitral annular calcification, the simulations, those are the dotted lines, are not very accurate. As you see, there are differences between the solid line and the dotted line. With the MACs, you see hardly any difference with valve in surgical rings or valve in failing bioprosthesis. So that tells you that you have to be very careful with simulations, CT-derived simulations of LVOTs in patients with MAC. So I think much more research needs to be done there. I already mentioned that in TMVR, the literature that we see now is literature that relates to a very selected patient population, because there is a lot of screening failure with all the current contemporary devices. And the major reasons for screen failure are the annular dimensions. Oftentimes the rings are too large for the contemporary TMVR systems, but also the high risk for LVOT obstruction, where a cutoff of 170 millimeters square or sometimes 189 millimeters square is used as a cutoff for an LVOT obstruction. What is then the future? Is the future newer transcatheter mitral valve platforms? To be honest, I don't think so. I think the future is electrosurgery. I think we need to develop the tools that Dr. Greenbaum and his colleagues are developing in terms of electrosurgery to modify, to preserve the left ventricular outflow tract by either septal modification, for instance, with a sesame technique, where you lacerate the septal wall and you open up the septal muscle, or you lacerate the anterior mitral leaflet and you create basically, or you prevent that anterior mitral leaflet from obstructing the LVOT as you are implanting the device. I think once we have developed techniques to democratize electrosurgery, I think then we will see a higher screening success and more patients will become eligible for TMVR. Are there some solutions on the horizon? Well, I am involved with, for instance, Valcare. This is an implant-free annuloplasty technology for both functional MR and TR. So basically, you use radio frequency energy to shrink the annulus, which is quite an impressive concept. I haven't used it myself, but it builds on a premise that had been developed already more than a decade ago, but this is a refinement of the technique. And if it would work, I think it might increase the number of patients that become eligible for TMVR because you make the annulus smaller, or sometimes you can also use it as a standalone annuloplasty therapy. I think more out of the box is also the concept of posterior leaflet augmentation or posterior leaflet replacement. And so rather than replacing the entire valve, you only focus on the posterior leaflet. And as I mentioned in the beginning of my talk on the mitral valve, it is the posterior segment of the annulus that has a tendency to enlarge, and it is the posterior leaflet that is a tether, that is going to tether if the annulus or the LV dimensions are enlarging. So it makes total sense to only focus on the posterior leaflet because you will not see the issue of LVOT obstruction. Multiple technologies are under development. You have Sutra, Carlin, mitral butterfly, and then the Mitria spacer, but special notification to the Polaris system and the Trapeze Reniva system, where I'm also involved. I think those are quite promising new concepts. So to summarize the takeaways for mitral therapies, the MR treatment is different in primary versus secondary MR. Also, procedure risk is different if you compare TEER with TMVR, with TMVR being the high-risk procedure. The guidelines have been modified. TEER has now a class 1 recommendation for selected SMR cases, and the aim there is to achieve a moderate or less residual secondary MR. But if you are in the space of primary MR, the stakes are higher, but also the objective basically is to eliminate residual MR. Multiple randomized controlled trials are ongoing. New technologies are aiming for annuloplasty, but also posterior leaflet augmentation. And also, similar to what I mentioned in the tricuspid space, I think we are moving towards a toolbox approach for mitral repair that allows us to more and more mimic what surgeons do in the OR. And then finally, I think ancillary electrosurgery techniques may be the way to go to increase patient eligibility for TMVR rather than the development of newer TMVR technologies. With that, Chadi, that was the
Thank you so much.
presentation.
Thank you so much, Dr. Van Mieghem. It's a great overview. I mean, we're finishing right on time. I just maybe one question from the audience. Are you aware of Edward M3 valve mechanism or valve trial and how it eliminate the worry about LVOT obstruction?
Well, yes. So I was also involved with the Encircle trial. This is the trial that evaluated the Edwards M3 device, and this is a two-step device, right? So you have first an anchoring mechanism that encircles the chordae, and then after that has been achieved, you have an anchor for a modified SAPIEN 3 29 millimeter valve to be implanted. The interesting part is that this is a technology that requires only a transvenous, transfemoral, transeptal approach as compared to HighLife, which is also a two-step mechanism with an anchoring around by encircling the chordae, but that requires a large bore arterial and a large bore femoral venous approach. So the M3 is a little bit more simpler and more intuitive. Is a two-step approach associated with less LVOT? The honest answer is no. Intuitively, you would think so, and that's also what I always said. But at the end of the day, the screen failure rate with the M3 is also 70 to 75%. And the majority, the main causes for screen failure are twofold. It's either the valve is too small. So sometimes the valve is too small for encircling, and then the 29 millimeter valve. And the other reason is still LVOT obstruction. So I think also there with an M3 device, you will need ancillary technologies if you want to get more patients eligible for the study, for this technology.
Another futuristic question is, do you think over the course of 5 to 10 years that these transcatheter therapy is becoming part of an earlier standard of care compared to surgery?
Yes.
Or surgery going to continue to mean?
Yeah. I think this is, not to be disrespectful to our surgical colleagues, but surgery to me is a technique of the previous century. And I think in this day and age, everything is about minimal invasive and catheter-based. And we will get better and better in mimicking what surgeons can do in the OR. And I think the two major breakaways or breakthroughs that we need are a percutaneous annuloplasty and a percutaneous neocord technique. Once we have that, then basically we also can offer a toolbox approach to our patients, combining an annuloplasty with either an edge-to-edge or a cord or whatnot. Yeah.
Last question related to CIED is if you have a TR that's related to lead, TR related to lead implantation, do you recommend removing the lead and see if the TR improve, or this tricuspid valve need to be repaired regardless if it is related to lead or not?
Well, it depends, obviously, if the patient is lead dependent, right? If the patient is lead dependent, then it's not so easy to remove. And there is also the risk of lead extraction. I think the first step there is to do a CT scan to really understand what is happening with the interaction between the lead and the leaflets. So, for instance, if the lead is perforating the leaflet, you can do whatever you want. You can take out the lead, but your TR will remain. So I think in that particular case, surgery will be the way to go. Or you might consider first implanting a coronary sinus lead, put in a lead in a coronary sinus, and then do a TTVR where you don't have to worry about
the opening. Now we learn from these mechanisms. Is there any, or are you working with EP colleagues to tell them you have to change your technique or have to be careful in placing that lead, because we see not a good big percentage, but at least enough to be lead related valve issues?
I think this is work in progress. For the time being, I think we are getting more and more grip on the problem of lead-related tricuspid regurgitation, but it's still, well, let's put it this way. I don't think that EP docs are a consistent member of multidisciplinary heart teams on valvular disease.
Right.
That said, what we do if we have patients with tricuspid regurgitation who have a lead, our first step is a CT scan, and then we invite our colleague EP docs to come and join us with a discussion on a multidisciplinary discussion on how to proceed, because they also are involved with lead extraction, so they then take a crucial part of the discussion.
Dr. Van Mieghem, again, thank you so much for a very insightful, detailed presentation on two complex valve problems, tricuspid valve and mitral valve regurgitation, which has been evolving. I think you're learning a lot from mitral and extrapolating to tricuspid, but turn to be a tricuspid valve is completely a different beast and different assessment. But I think the future is there and the technology is evolving quickly to help these patients.
Absolutely. Chadi, thank you very much for having me. For you, your listeners, all the colleagues out there in Michigan and in the United States and all over the world, happy holiday season and a happy new year.
Thank you so much again. And thanks for our, as you said, viewers. And this is our last session of this year. Happy holidays and happy new year. And we'll see you everybody on the third Thursday of each month next year in 2026. Happy holidays. Bye, Nicolas. Thank you so much for your time.
Thank you, Chadi. Thank you. I hope it was well.
That was amazing. Thank you so much.
Ciao.